So good morning. I'm going to assess the thorax and the cardiovascular and the breasts of male and female. So to start, I'm going to wash my hands, perform hand hygiene to prevent the microorganism. Then I'm going to identify the patient. What is your name?
My name is Riza
And I am Mariela. I am your nurse today. Patient identification validates the correct patient and correct procedure. Discussion, explanation help vary allay anxiety and prepare the patient for what to expect. So I'm going to close the curtains, close the door to provide privacy to the patient. And I'm going to adjust the head of the bed so the patient can tolerate, and I'm going to raise the bed a height that is hip even with the transport stretcher. So closing the door and the curtains provide privacy, and proper bed height and lowering the side rails transfer easier and decrease the risk of injury. Then I'm going to place a bath blanket over the patient to provide privacy and warmth to the patient. Then to start, I'm going to assess the thorax. So I'm going to let the patient to breathe normally. Can you breathe normally? Again. So as what I have observed, the patient can breathe normally and comfortably while sitting with her arms at rest. Then I'm going to move around slowly at the back of the patient, and as I do this, I'm going to assess the anterior posterior diameter and the lateral diameter of the thorax. So as what I have observed, I observed that normally the lateral diameter is up to twice the anterior posterior with a ratio of 2 to 1, which is normal to find at the back of the patient. Now I'm still standing at the back of the patient or behind the patient. I'm going to use the pads of my fingers to palpate the spinous process. So as I palpating, the spinous process is evenly spaced and non-tender. And I'm going to assess the respiratory expansion. To do this, I'm going to place my thumbs at the level of the T10 or the 10th thoracic vertebra, and I'm going to spread my fingers, allowing them for small folds and of the skin between my thumbs, and I'm going to let the patient to breathe deeply, slowly. And as she does this, I'm going to watch the respiration of her skin on my thumbs. And as what I have observed, the movement moves symmetrically. Then, I'm going to assess the tactile firmitus or voice sounds to the patient as I palpate the chest wall surface using the ball of my hands to feel for vibration of the patient as she repeats the phrase 99. Can you say the 99?
99, 99, 99, 99, 99, 99.
So as I palpate with the ball of my hands, the vibration in each location is equal vibration. So next, I'm going to perform immediate percussion using a systematic pattern so I can compare the two sides. So as I perform immediate percussion, the resonance should be equal over the lungs, where I should feel the dullness over the diaphragm. And if there is a hyporesonance, it means that I have found an area with this increased air of the lungs or the pleural space, as with it is a pneumothorax or acute asthma. And if it is an abnormal dullness, it indicates decreased air in the lungs, which indicates a atelectasis or buildup fluid or the pleural fluid. So I'm going to assess the diaphragmatic excursion. To do this, I'm going to ask the patient to exhale deeply Can you exhale and hold your breath? So as she exhale, I'm going to mark the point where I can feel the dullness. So as I feel the dullness, I'm going to mark this point. So I'm going to let her breathe again. Inhale. So as she inhale, I'm going again to mark this point. Then I'm going to repeat this on the other side. So as I repeat this on the other side, it measures 3 to 5 centimeters, which is equal to both sides. So what I have observed, I measure 4 centimeters, and it is also 4 centimeters on the other side, so that is normal. Next, I'm going to assess the kidney as I use the blunt or fist of my hands to percuss the costovertical angle. So as I percuss in the area, I don't feel any cause of tenderness. And finally, I'm going to auscultate the breath sounds with the diaphragm of my stethoscope. And to do this, I'm going to instruct the patient to breathe deeply to her mouth, starting at the lung apices. Auscultate the lung, I will auscultate the lungs, and move systematically from side to side, down to the patient's back, and laterally toward to the axilla. And be sure to listen for at least 1 complete respiration at each location. And as I auscultate each location, I hear normal breath sounds within the area that I am assessing, and you should hear a bronchovesicular sounds between the scapula, which the sounds are moderate in pitch and amplitude, with inspiratory pace equal to the expiratory pace. And also, you should hear a vesicular sounds at the apices down to the bases and laterally. These sounds are low pitch and soft, with longer inspiratory than the expiratory pace. Now, I'm going to listen for abnormal sounds such as crackles and wheezes, and for coughing. So, can you cough for... So, as she cough, I'm going to listen again. The abnormal breath sounds have clear. So, as I auscultate for the breath sounds, the crackles which can be heard on inspiration and sometimes on expiration results from collapse or fluid-filled alveoli popping eyes. And if there is a fine crackling or sometimes a bubbling sound, and wheezes also can be heard on both inspiration and expiration, which are high or low pitch, and it indicate an airway obstruction. Next, if you suspect an abnormality, have the patient to say 99 as you auscultate the areas. So I'm going to auscultate the areas. Can you say 99?
99.
And normally, the words sound muffled and indistinct. Now, I'm going to assess the anterior thorax. Begin with the bones and muscles. And what I have observed, they appear symmetrically, and I should not see accessory muscles, use or retractions or bulges on the anterior thorax, and the patient should not have signs of respiratory difficulty such as cyanosis, which is the bluish skin discoloration, or the nostril flaring. And now I'm going to palpate the thorax with the finger of my pads to move from lungs to apices to the bases. And I don't find no nodules. Next, I'm going to assess the respiratory expansion. I'm going to place my hands on the patient's chest along the costal margins with my thumbs. I want you to sleep. I to deep slowly breath. And as I inspect, it moves simultaneously and symmetrically. Next, I'm going to assess the tactile firmitus as the patient repeats the phrase 99. I'm going to move from the long apices down to the point below the nipples, comparing the sides.
99, 99, 99, 99, 99, 99.
Then, I feel that the variation is equal but stronger in the upper chest and in the lower chest. And next, I'm going to perform percussion over the lungs using a systematic approach starting above the clavicle and the clavicle and percuss the intercostal spaces from side to side, and as I percuss, it produces low resonant sound. Then, I'm going to auscultate over the patient's lung with the diaphragm of the stethoscope in the same pattern I use for the percussion. At each location, I'm going to listen for complete respiration. As the normal breath sound is heard, it may vary the area which I'm assessing. And I should hear a tracheal sounds over the trachea, which this is a high pitch, loud, and tubular. And I should hear a bronchovesicular sound laterally and over the bronchi at the angle of Louis. And over the bronchi at the angle of Louis, I am expecting to hear a vesicular sounds over most of the anterior thorax and the periphery. And if you suspect a abnormality, have the patient to say 99 several times as you auscultate the areas involved. Can you say 99?
99, 99, 99.
So normally the words sound muffled and indistinct. And next, I'm going to assess the cardiovascular aspect of the thorax. So I'm going to help the patient into semi-forward position. Can you lay? And check for apical pulse spaces at the mid-clavicular line to help visualize the pulse better, so you can repeat the process which the patient on his left side. So I'm standing at her right side. So of what I have observed, in about half of patients, her apical pulse isn't visible. So I'm still standing here on her right side. I'm going to palpate the apical pulse even if it's not visible. And I should feel a short, gentle tap and should be palpate in an area about 1 centimeters by 2 centimeters. Next, I'm going to use the ball of my hands systematically palpate the heart's borders in the sternoclavicular area, aortic area, which is here in the pulmonary area, and the left ventricular area, which I will take note any heaves of vibrations. Next, I'm going to auscultate the heart at the right second intercostal space close to the sternum, along to the left sternal border in each intercostal space from second through the fifth intercostal space. And as I auscultate using both the diaphragm and the bell of the stethoscope, determine the patient's heart rate and rhythm and listen for a normal heart sounds S1 and S2. S2 is best heard at the base of the heart here. It corresponds to pulmonic and aortic valve closure at the end of the ventricular systole, and S1 is best heard at the space as at the apex and it corresponds to mitral and tricuspid valve closure at the start of the ventricular systole. Then it should coincide with the carotid pulse, and especially I'm going to note the timing of the heart sound in relation to the cardiac cycle and stay alert for abnormal heart sounds such as S3 or ventricular gallop, which may be a cardinal sign of the heart failure, and S4 for sumination gallop, which it results the vibration caused by forehead ejection of blood from the atria into the ventricles that expand less than they should. Now I'm going to assessing the breast of the male patient. Now I'm going to continue by assessing it. So what I have observed, the breast of the male, it should be smooth with no nodules or tenderness. Next, I'm going to take note for if there is a gynecomastia or breast enlargement, which is normal in males only during puberty. And next, I'm going to palpate the nipples and breast tissue, checking for nodules. As I palpate, I don't find any nodule. Next, I'm going to check the axilla. As I check the axilla, it should not have no enlarged lymph nodes. Next, I'm going to check the breast female patient, and I'm going to inspect the breast. As I inspect the breast, in most women, one breast is slightly larger than the other. Then the breast should be smooth with no redness, lesions, dimpling, or extreme vascularity or retractions, and lymph nodes in the breast area should not be visible or bulging. Next, I'm going to assess the nipple. As I assess the nipple of the patient, I see asymmetrical and no scaling, discharge, lesions, swellings, or redness, or bleeding on her nipples. Next, I'm going to watch the patient as she raises her hands and press her hands on the hips. And can you lean forward? And in each position, the patient I should see no puckering, dimpling, or retraction. As the patient leans forward, her breast should swing freely, and as she leans forward, her breast swing freely. Now I'm going to use the pads of my middle fingers to palpate the axilla to assess the lymph nodes. Can you raise your hand? So as I'm palpating, be sure to reach the pectoral muscle and move your fingers toward the clavicle and down against the ribs, which there are small or freely movable lymph nodes, which is normal. Now I'm going, and you should instruct the patient to lie down and place a pillow. So I'm going to place a pillow under your shoulder, and I want you to raise your arms. And as she raises her arms, I'm going to use the pads of my middle finger using a circular motion to palpate each section of the breast, starting at the nipple, moving around in a concentric circles. And as you do this, teach the patient to proper palpation technique and encourage her to do a breast examination monthly. And I'm encouraging you to do a breast examine every month. Then, if you prefer, you can use as in a E pattern when you palpate, or you can sweep your finger pads across the breast. And no matter which pattern you use, be consistent. And remember to palpate the tail of Spence. And I'm going to palpate the nipple, compressing it gently. And I do not feel any detect of induration or masses. And if you see nipple discharge, obtain a culture. If you suspect a mass, try to elicit dimpling by moving or compressing the tissue, and check the opposite side for symmetry. If you find a mass, document the size, the shape, or the color of the nipple, or the tenderness. And when documenting your findings, mentally divide the breast into 4 quadrants, or using a clock face, imagining the breast. Then check the epicuticular lymph nodes by palpating the groove between the biceps and the triceps muscle. And as I palpating it, I don't feel any nodes which is enlarged or tender. And after the procedure, raise the side rails and make the patient comfortable to ensure the patient's comfort, and cover the patient with blanket and remove the bath blanket if on the underneath of her if she's using a bath blanket, because side rails promote safety and bath blanket provides privacy, comfort, and warmth to the patient. Now I'm going to remove my PPE if I am wearing, and I'm going to perform a hand hygiene, because removing PPE properly reduces the risk of infection or diseases transmission, and performing a hand hygiene to prevent the spread of microorganism. Then I'm going to document all the findings for further diagnosis and examination. Then that's the end of the assessing of cardiovascular and the thorax and the female and male breast, and that will be all. Thank you.